coverage alone is insufficient, right? Just having an insurance card doesn't mean anything if you actually can't get the care that you need. And I think we are making strides in that regards as well. And I think California, being in the leadership of implementing the ACA, we are now also taking leadership in addressing the next set of issues that come up with the ACA. Because I think the ACA sets a foundation that we have to build on. Now that we're expanding coverage and reduced the number of uninsured by half, yay, we did that. That sounds good, and we got to continue to work on that because we still need to work toward healthcare coverage for everyone. We also need to be sure that that coverage actually means something, and that's, I think, I know what you're talking about here today.
The truth is that the first year of Obamacare implementation in California and in the United States was rocky, and its effects on patients were inconsistent and uneven. There have been major challenges for consumers. The faulty Covered California and healthcare.gov websites continue to pose challenges for consumers to this day. However, things are definitely better than they were the first time around.
You know, a lot of the issues that we're going to talk about that are challenges have existed far before the ACA was ever passed and implemented. So things like having difficulty finding out what doctors are covered, having difficulty finding out if your drugs are covered, just understanding health insurance in general. That's always been a challenge, and the ACA has really kind of pushed us to start having those conversations again about how to fix those problems.
It's really energized all of our organizations like I haven't seen in a long time to say we've got to do something about this because people are not, it is unaffordable and it's inaccessible. So how do we build quality into a system that doesn't allow people who are the sickest, who need the care the most, the ability to get the medicines that they need to keep them well.
It's so important for the right drugs to be on the formulary, especially as we're moving towards more personalized medicine.
So I think there are solutions out there, and these could be handled at the state level as well, or at the federal level. But I think that is the issue that we're all talking about. It's this use of co-insurance and high patient
And when a health plan denies care, they have to provide the enrollee a letter. They have to state that denial in writing. And they have to indicate what they're denying and why they denied it. And if it's a medical necessity denial, they have to provide the clinical rationale for that denial and advise the enrollee of the right to file a grievance.
When we heard from the American Cancer Society, the National MS Society, that they felt that the prescription drug plans sold in Montana in 2014 were discriminatory, we took it seriously and knew that we had to do something about it. We didn't know anything about it. So we felt that you can't treat someone with cancer or HIV or diabetes or MS or hepatitis differently because they had to take the specialty tier drugs than those who had similarly serious medical conditions yet were in the lower tiers, and they could, because of that, spread their costs out over the year. That inherently is discrimination. It really is kind of illogical that carriers are going to say, well, we're going to have co-insurance, people get off their medication schedule, and then they're going to be hospitalized, and it's going to be more expensive, and premiums are going to end up being higher. This is similar throughout the country in various states. There's a variation of this state statute in every state in the country. So to hear from other insurance departments that they cannot do this, I think, to be blunt, is a cop-out. We think it can be a model for other state insurance departments, and we've urged them to. We would urge the California, respectfully, of course, the California Insurance Commissioner to do the same.